Hey, it's Dr. Centeno, and thanks so much for joining me this afternoon/evening. I think this will be our last day of doing this on Thursdays. Next week, I think we'll switch back to Sundays, and then over the Thanksgiving week, we'll do a Sunday there as well. So, got an interesting topic tonight, primarily because, as you know, I normally talk about something that happened during the week or something I get asked about a lot. And this is one I get asked about a lot, right? What type of flare-up should you expect with a PICL procedure? What does that look like? Is there anything I can do to mitigate that? How would you mitigate that? Et cetera, et cetera, et cetera. So we're going to get into that today. And as usual, I'll spend a little time talking about this topic, maybe 10 minutes, and then I'll do Q&A for the rest of the time. And you can ask a question about this or anything else. And at the same time, to ask a question, just go ahead and put your question in the comments, whether you're on Facebook or YouTube, and I'll see it here. Again, just before people get here, I'd like to go into that. I think this will be our last Thursday for a while. I've got some stuff I've got to do this weekend, but starting next weekend, I'll be free to move this back to Sundays at 10. And then for the Thanksgiving week, I think we'll do the same thing, Sundays at 10 a.m. MST, that's noon EST. So again, topic today is what kind of flare-up should you expect with an EPICL procedure? How do you mitigate that? Which patients tend to flare up more? Which patients tend to flare up less? That kind of stuff. So 10 minutes of this, and then we'll get into Q&A. You can ask questions about this or anything else. And if you're on Facebook or YouTube, just put your question in the comments. And then we'll be able to see that here, and I can then answer your question. So let's get started with the topic at hand today, which is what type of flare-up should you expect with an EPICL procedure? So really all patients experience pain or discomfort after an injection or a surgery. That's pretty much standard, no matter what kind of procedure you get. Now, obviously, with smaller procedures, you tend to see smaller flare-ups. With bigger procedures, you tend to see bigger flare-ups. With PICL, in general, we see more flare-up than we would with something like a posterior PRP injection in most patients. But we've got a pretty broad response, which is really what brings this question up so much. So why do some people shrug this off? Because I literally have patients that tell me, I was a little sore, but no big deal. I kind of went about my business. Maybe I threw down some Tylenol. I never really used any of that pain medication you gave me. Versus patients that can go the other direction, right? Patients who are more significantly sore for much, much longer. And so what's the difference between these two polar opposites? Because again, I see both. Obviously, I see most patients in the middle of that, but on extremes, I see both of those. So I put this together and put it on the Reddit thread. If you haven't been on the Reddit thread, I answer questions there 24/7, 365 right now. And I put this on there because I kept getting this question on the Reddit thread, so I wanted it to be there. And I made this little diagram specifically so patients could understand how I think about this flare-up. So for those of you that remember a high school statistics class or college statistics class or the general concept of statistics, there's one standard deviation from the mean and then two standard deviations from the mean. And about 2/3 of everyone is going to fall one standard deviation from the mean. And if we get out to two standard deviations from the mean, which is 2 SD here, then we're going to get about 95% of all the patients. And then we'll have tails that go off 2.5% on each side. So if we look at that, we can see here this 7 to 10 days So I've got this 7 to 10 days between those 1SD bars. And that's where most people are going to fall. They're going to have 7 to 10 days of increased symptoms, but it's going to be manageable, right? They'll maybe spend the first couple days taking some pain meds. And after that, each day, the pain will get better and better. And by the 7th or 10th day, they'll go back to normal or close enough where they just kind of go back to their regular activities. Then we get out to 2 standard deviations from the mean. And now we're picking up a little bit more, or a little bit fewer people on either side, right? So maybe another 15% on either side. And we have both sides of that coin. To the left side there, we have less flare. So those are people who just have a couple days of flare up and that's it. And then to the right, we have more flare up. And again, in that additional 15% of patients, they might go for a couple weeks of flare up. And then finally, we have the bottom bar, that left, right, where it says no flare to months. And that's where we pick up the extremes on either side, where we've got some patients who are like, I don't know that you did all that much. I didn't really feel much, versus people who take months to get through a flare-up. Now, that's pretty rare, taking months to get to a flare-up or through the whole flare-up, just like it is on the other side. Pretty rare to see someone who says, I didn't feel all that much. Did you do something to me? But I see both of those extremes. So again, to review real quickly, for most people, about 2/3, we get 7 to 10 days of flare-up. For another 15% on either side, it's a couple days. And then on the other side of that coin, a couple of weeks. And if we add in the extremes on both ends, what we'll see is that we get literally patients who say, did you do something to me? Because I didn't really notice it all that much. Versus people who take a couple of months to recover from a post-procedural flare-up. So obviously, this is pretty wide variation, right? Now, this is probably not atypical for procedures that are bigger, but I think in the CCI population, we tend to see this bigger difference between the extremes. We've got functional patients who don't really feel much, and we've got some very severely sensitized patients who take a long time to recover. But again, they tend to be at the extremes of even the CCI population. But there's probably more of those extremes in that population than other patient populations. And if we were to look at fusion, obviously it would look similar to this, but probably longer numbers. The whole thing would probably shift to the right, where we would see much longer recoveries. And even on the short end, yeah, I definitely know you did something. So what are the top 5 drivers of post-procedure flare-ups? So the first is going to be central sensitization, and we'll go into what that is. The second is going to be high levels of systemic inflammation. Then we've got pre-op meds, then we've got functional level, and then we've got cannabis. So let's go through all of these. Central sensitization, what does that mean? It means that very small stimuli, like a physical exam, a massage, or a small injection, causes an outsized response from the central nervous system. The mechanism is that the patient's ability to carry pain signals is amplified, and the internal neurology that's there to dampen pain signals is compromised. So they really can't control pain like a normal person. Now, we've learned a lot about central sensitization because the drug companies got in on central sensitization. I hate to put it that way, but there was an on-label indication for central sensitization in Lyrica, really what used to be called fibromyalgia, now is called central sensitization. And so there was a lot of money all of a sudden in treating central sensitization because a drug could do it. So there was a lot of research that went into what is central sensitization. Can we image it? Yes, we can with specialized functional MRIs. Is it real? Yes, it is. What happens? How does it occur? What's the mechanism of action, et cetera, et cetera. So what are some solutions? Well, the first biggest solution for central sensitization in CCI patients with a PICL or other procedure is to take the less is more approach. What is less is more? What that means is that I'll reduce the number of sites that we inject, and I'll take out some of the ones that generally cause more post-op pain to try to meet the patient where their central nervous system sensitization is. And now that doesn't mean that we might not do more on a second or third try, but for the first one, we're going to scale it back until we see how that patient's body responds. And then once we do, we can kind of open up the floodgates a bit. Now, like I said, there are medications like Lyrica that can reduce nerve sensitivity. So that's another option medication-wise. Lyrica tends to work pretty well for this. It does have side effects like most medications do. Next one is high levels of systemic inflammation. What does this mean? The patient's system has high levels of systemic inflammation, swelling, etc. Now, realize that I see a lot of patients that self-diagnose with this or patients that have been told they have high levels of systemic inflammation, but these are some fairly esoteric lab tests to show something like this, like TNF alpha levels, etc. Now, we know from lots of different research studies, for example, I'll give you an interesting one that's always blown me away, is that we can take a herniated disc patient in the low back, and if they have low levels of systemic inflammation, that herniated disc only takes a couple weeks to resolve. But we take the same herniated disc and put it into someone with high levels of systemic inflammation, and now it takes them 9 months to resolve. So we kind of know that there's also a patient population out there where a small inflammatory event has an outsized whole body inflammatory response. And we're learning more and more about that as time goes on. Almost like a little campfire burns down the whole forest. So what can you do if you've got systemic inflammation? Well, there's a couple different things. A lot of our patients are already on some of the drugs that might control this or mitigate it. Obviously, we can try the less is more approach, as I've talked about. Something else, a good trick after the procedure, don't do it before the procedure, because if you do it before the procedure, that can lead to increased bleeding during the procedure. But you can take high EPA, DHA fish oil, the good stuff, the expensive stuff, something like Nordic Naturals, which is what they sell on Amazon. And that has what's called resolvins that can help to resolve an inflammatory response. So those are some tricks. And again, some patients are already on some medications to manage this, because this gets linked in with mast cell disorder and some of the other autoimmune type things. Pre-op meds. A big problematic med scenario is obviously someone who is on narcotics prior to the procedure, or someone who really can't function without a specific medication. So we see patients that can't function without taking a nonsteroidal anti-inflammatory drug. That should say NSAID there instead of NASA AIDS. Sorry about that. Headaches or other medications. So basically, maybe someone can't survive without taking their CGRP migraine med, or they can't survive without taking Celebrex, or they can't survive without taking some other medication. And then we've got patients who have poorly controlled pre-op pain. So it doesn't really matter what they take, it doesn't really put a dent in their pain. So these are patients who are going to have a bigger flare-up in general. Patients on narcotics already are going to have a bigger flare-up. Patients that can't function without a specific med are probably going to have a bigger flare-up, because we may have to stop those meds and then restart them later. so that those meds don't interfere with the inflammatory response that we want. And then we've also got patients with just poorly controlled pre-op pain, and I think they do the worst of everybody, meaning that, and that's on the extreme, right? When I talk about a patient like that, I'm talking about patients that I remember from the past who come in and say, I've got 10 out of 10 pain, doesn't matter what I take, it's always 10 out of 10 pain. That person is going to have a flare-up that's going to be very hard to control post-op. So what are some solutions? We can change the medications to mitigate a post-op flare if that's possible. And if not, less is more. So for example, getting them off of, let's say, a non-steroidal anti-inflammatory drug, and maybe trying to substitute high-dose curcumin and fish oil, having them stop the fish oil for maybe 2 weeks before the procedure and then start it right back up after the procedure. Another possible solution might be to switch them to a different medication that might make it easier to recover. And then obviously we can always take the less is more approach. Functional level, this one's kind of obvious, right? Low functioning patients in general tend to have a bit more flare up. Now, this isn't a hard or fast rule because sometimes high functioning patients do. But if I compare high functioning patients to low functioning patients, meaning patients that can't get out of bed, the patients that can't get out of bed are generally going to have more flare up than someone who is relatively high functioning. Some of the things we've used is prehab with Todd Ball, meaning working with Todd Ball on the prehab program, where you can actually do rehab before the procedure to try to get a little bit stronger, to try to work on postural things, even if you're very low level. We found that to be very helpful. And then finally, cannabis. We now have pretty good research that shows that cannabis is a real problem for any procedure or surgery, in that it dramatically increases anesthesia requirements and that it makes the patients have a tougher recovery. So this one's usually pretty easy to solve. Get off the cannabis products prior to the procedure, or certainly stay on them, but realize that anesthesia may be more difficult and higher risk, and the recovery may be more difficult. So I've literally had now dozens of patients where they didn't really get off cannabis for the first procedure, tough to do the procedure, tough to get it done, tough to keep them asleep, rough recovery, and then they got off it for the second procedure. I go visit them in the PICL area, and the first words out of their mouth is, wow, that was a lot easier than the last time. Yeah, because we could much more easily keep you asleep, and you don't have that problem caused by cannabis, which is we have to use massive amounts of medications to keep you down. So the whole thing is going to be just much rougher for you. So I'll end again with this little diagram, and all it means is that the vast majority of patients are going to have 7 to 10 days of a flare-up. Then we're going to see another 15% or so on either side. On the no flare-up side, about 3 days. On the more flare-up side, about 3 weeks. And then we've got the tiny little parts on the end, the tails on the end of a couple percent of patients who are going to have almost zero flare-up, if that's possible, to more months of flare-up. So that's really what I wanted to talk about today. Let me get to questions because we got a load of questions coming in. Also, do me a favor, give me a like, share, comment, subscribe. If you want to help out the CCI community, they have to be able to find this information, and they're never going to be able to find it unless you like this, share, subscribe, etc., because that's how the algorithm determines whether or not this is important content that other people might be interested in that are searching for information on CCI. So help out other patients by doing that. Okay, let's go to questions here. Pre-PICL number 1. Let me first get rid of this share here. Okay. Pre-PICL number 1, it looked like 3 days incapacitated in bed with 8, 9, and 10 headache, pain, facial nerve pain, lack of temperature control, felt really cold, nausea and vomiting, and a CCI 2A and 2B. And I think there might be more to this. Post-PICL flared up about once every 4 to 6 weeks, did not have a severe pain, shorter duration, and no vomiting, yay. So maybe that's for PICL number 2, I think. And then this one, 10 weeks out from second PICL, only 2 flares so far. Overall doing fabulous. Atlas held 31 days now. Now not holding along, but stronger and doing much better. And then finally, after first PICL, had more challenges, but took 3 months to recover. Only took medicine for about 4 days. Same for second PICL, only 4 days. Didn't take any OTC-RX in the flare-up for others. So it sounds like the patient had a much harder, rougher recovery with the first one than the second one. Not uncommon. We often see that where as we go, the flare-up tends to be less, the first one being worse. In addition, some of that could be possibly due to the new 5th generation mouthpiece. We've been seeing fewer flare-ups with that mouthpiece, and I think that's often related to better airway management during the procedure. So that's another possibility there. But thank you for letting us know that. Carol, submitted advanced by Sherry Scott. Does being in good physical shape before injury make any difference in the recovery? Yeah, I think that if you have more muscle mass, more stability, or in better physical condition, anything you do, whether it's a surgical procedure, an injection procedure, is just going to be more likely to not really upset the system as much. I think as people get sicker and less in shape, for instance, they end up having more problems with blood sugar control. They put on some weight, blood pressure control, they start getting metabolic syndrome. That stokes inflammation, and we tend to see harder problems or bigger flares from procedures. Flare for me was involving brainstem compression. Neurological symptoms knocked me out, but for the first week post-PSL, neurological symptoms until I overdid and had 2 days flare. Gotcha. God always wins. Hi, Dr. C. You mentioned that there were only 5 doctors performing surgeries for CCI patients. Who are the 4 in the U.S. and what states are they in? Yeah, so the 4 I see all the time. I see Patel a little less now. Dr. Henderson in Maryland, Dr. Bolognese in New Jersey, Dr. Patel in, I want to say it's North Carolina, but this is probably awful to people that live in North and South Carolina, like North and South Dakota. We non-Dakota and Carolinian people often get those mixed up, but let's say in the Carolinas, you can find him at Sunil, S-U-N-I-L Patel. And then we have Dr. Frank in Florida. Ex-US, we have Dr. Gillette and Dr. Oliver, both in Barcelona, I believe. Gabapentin 2. Maybe this is about whether or not gabapentin works as well as Lyrica for central sensitization. In general, no, I haven't seen gabapentin work as well as Lyrica for central sensitization. I think gabapentin is a little bit more hit and miss, whereas pregabalin, which is Lyrica, tends to be more reliable in treating central sensitization. OG Dirty Rat, how soon after posterior PRP injections should you start threading the needle? 1 day, 3 days, 1 week, 2 weeks, or should I let pain be my guide? Yeah, so the real concept behind threading the needle for rehab or recovery is letting pain be your guide. So for example, I often tell patients when you should start getting back into something is when your pain returns to baseline. Now, for some people, that might be day 2. For some people, that might be at the end of the first week. For some people, that might be at the end of the second week, or as you can see, for a minority of people, it might take longer. But that's when you can start getting involved in rehab, because that thread the needle means let things calm down and then start doing things, and then let your flare up be your guide about how things go or how much you should do going forward. God always wins. If a person has mild to moderate spinal canal compression at 5'6", is that call for automatic surgery? It is not. I've got moderate to substantial central canal and foraminal stenosis at 5'6" and 6'7" on my neck. Never had surgery at this point. I'm getting old enough where I don't plan to. Now, we've treated with orthobiologics here and there, but I don't need any surgery. So no, that doesn't really determine whether or not you get surgery. What determines whether or not you get surgery is how symptomatic that is. Can it be managed without surgery? Because realize that if we take 100 people my age off the street right now who have no neck issues at all, we're going to find about 40% of them with that on their imaging, meaning 40% are going to have moderate or mild stenosis on their imaging, and they don't have any symptoms at all. So that doesn't define much of anything. Jonathan Diaz, structural BP issues improve with CCI. I don't know what you mean by structural BP. If you mean whether or not blood pressure issues caused by, let's say, irritation of the vagus nerve or the sympathetic nerves due to craniocervical instability, then yes, those tend to resolve. But also realize that in a lot of patients I see, sometimes the blood pressure issues they have are caused by inactivity, caused by taking too much Tylenol, which also increases blood pressure. So just realize at the end of the day, if they're being caused by CCI, then yes, that generally resolves. But there's lots of things that can cause blood pressure issues. OG Dirty Rat, how soon after posterior PRP injection should I start threading the needle? I think I got that one already. Is FM an autoimmune disorder? Maybe FND, fibromyalgia? Maybe FM here means fibromyalgia. There really isn't something called fibromyalgia anymore. We've switched the naming of that to central sensitization. So is central sensitization an autoimmune disorder? No, it doesn't seem to be related directly to the immune system. It's more related to an out of control central nervous system that's not doing its job at transmitting pain signals normally and inhibiting pain signals. Mike, what is the timeline you usually like to have between the first and second PICL procedure? Yeah, Mike, the timeline is going to really be very earliest 3 to 4 months and sometimes longer. So for most of our patients, we'll take a look at month 3 or month 4 as to whether or not they've improved and we're heading where we need to head. And then if we do, then we'll schedule the second one. Now, we certainly have patients that are on a faster timeline. Let's say they want to schedule the second one automatically at 3 months or 4 months. That can be done, but just realize that we always check in to make sure that someone is heading the right direction. And if we do go forward, that we're really trying to do what's best for the patient, not just get another procedure out of it. Courtney, what injection areas cause the highest post-op symptoms? You know, Courtney, I think probably some of the single hardest thing to tolerate for most CCI patients is putting bone marrow concentrate into the facet joints. That one is a harder one to recover from. Consequently, we generally start patients out with high-dose leukocyte poor PRP in the facet joints, and then we can move some patients who can tolerate it into bone marrow concentrate. Now, having said that, many times we're getting bone marrow concentrate into the 1-2 joints because that happens as we're injecting some of these ligaments. But that's probably the hardest thing to tolerate for most CCI patients. But realize tolerance also relates to the volume of work as well. So if we do 2 things, it's going to be less likely that that patient flares up versus if we do 20 things. Brian, do you agree with the recent publication of intradiscal injections that repeat injections are higher risk? You think any length of time between injections mitigates risk? You'd have to put that PubMed link down there, Brian, for me to take a quick look at which publication you're talking to or sort of talking about. The biggest issue with any injection that uses corticosteroids is that corticosteroids always increase the risk for infection if you go do anything else after you've had a corticosteroid shot in that area. So that could be a second injection. That could be, for example, getting surgery on that body part, etc. So I'd have to look at what it is they're talking about specifically. Are they talking about putting corticosteroids in discs? Are they talking about doing discography or discograms? What it is they're talking about would be helpful to know. J5, my spinal canal fluid is narrowed at C4 through 7 because of bulging discs. If the fluid doesn't flow freely, what kind of symptoms are associated with it? And does PRP help that area? I don't think I'd be concerned about your spinal fluid flow due to bulging discs, meaning, again, most people my age will have bulging discs in those same areas, and they have no symptoms at all. So bulging discs by themselves don't mean much. They're as part they're as big a part of normal aging as are wrinkles and losing facial fat and all the other things that happen as we age, or losing muscle mass, etc. It's basically a sign of wear and tear. Now the question then becomes, are those areas symptomatic? And that's a combination of looking at the imaging, doing a hands-on physical exam, getting a history from the patient. Diana, what if I have a very weak, tight jaw? How will that work if I have to have my mouth open with a PICL? I'm scared to make my jaw worse. Yeah, Diana, this is a common question I get. In general, we don't see this issue, meaning that at the end of the day, we have patients with TMJ and CCI, and that's about 1 in 3 of our patients. Probably about 1 in 5 of our patients are treating both the CCI and the TMJ at the same time, and we generally don't see any problems after the procedure related to the use of the mouthpiece. That probably has to do with the patients who have more severe jaw issues. We're treating the jaw at the same time. So it's really been a non-issue to date, and we've had a lot of patients with TMJ because such a high percentage of CCI patients have TMJ. KS, I take Nordic Naturals, omega-3, and turmeric. I never found medication to help with a CCI flare-up, so I started taking anything years ago. I just waited out those days in bed. Yeah, so I think that's great. Nordic Naturals plus turmeric, that's a good anti-inflammatory regimen. So I think I would continue taking that because both of those have other health benefits. Now, if you wanted to get a surgical procedure or something like a PICL injection procedure, you would have to come off of the omega-3 about at least 1 or 2 weeks before the procedure, because omega-3s can cause increased bleeding times. So just realize that that's something that would have to happen. It's been advanced by Harry Winston. What is the average amount of time needed to recover from a EPICL procedure? Yeah, Harry, I think we got that one covered here. Now, this is the flare-up, which would be the, quote, recovery. Now, another way to look at recovery would be what's the maximum time to healing? And in that case, maximum time to healing is going to be, for most patients, 3 to 4 months to get, let's say, 80% of the benefit. Some patients are slower healers and find that it takes 6 months or more. It just depends on the person. For younger people, less. For older people, more. And then we've got some people that just take longer to recover irregardless. Again, do me a favor, give me a like, share, comment, subscribe. That's how people find this content. If you want to pay it forward to the CCI community, you have to do that because there are other patients out there like you who don't know this exists. They don't know that I answer questions once a week. They don't know that there's a Reddit thread. They don't know that I even have a YouTube channel. And if you want to make sure they can find it, that's the way the algorithm will tell them that this information would be helpful to them. Courtney, with a post-op flare-ups, let me start again. Courtney, with post-op flare-ups, is it logical to go back to AO Chiro and get adjusted if needed, or is it best to wait it all out? Yeah, so this is another question I get pretty frequently, right? These are patients who do really well with AO or NUCA or orthospinaology or Blair. And they come out here, so they don't really have access to that individual that's been helping them temporarily. And then they get a post-op flare-up. Now, so for example, this week, I had one of my patients who had already contacted a upper cervical chiropractor out here. She was actually having some issues with rapid heart rate and blood pressure. We treated her, that kind of went down a bit, but was still a little bit high. And she went to the AO doc and it, boom, came right down. So most of our patients don't do that, but we do have about 1 in 10 to 1 in 20 of our PICL patients that feel very strongly that they want to see an AO chiropractor out here. The biggest issue is probably going to be getting your local AO, NUCA, et cetera, to communicate with that provider so they know what the vectors are, what to expect, what you respond to, all of that good stuff. Mike, well, Mike, this is so long, I got to come up like this. When I was finding a chiropractor for treating CCI, which is better, upper cervical, SOT, working with a great chiropractor for the year, should be a concern that he is not registered. Yeah, Mike, so there's different kinds that we generally recommend. First type we generally recommend would be AO or NUCA. Blair or orthospinaology also works. SOT, I don't have an opinion on at this point. But listen, if you've got a great relationship with a chiropractor and he's or she is able to help you, then I really wouldn't worry about are they registered or are they not registered. At the end of the day, you found someone who can help, and that's all that really matters to me. Linda, I found a highly qualified MAT, muscle activation technique, practitioner in Ontario. My shoulders and upper body have major imbalances and a lot of atrophy. How soon after my first PICL would it be reasonable to meet with this practitioner? I don't fully understand how aggressive this is or what's involved. Yeah, so muscle activation technique or muscle energy technique, a little bit different, but listen, I think, Linda, the best thing to do would be to start with someone like Todd Ball, see how you respond to that. Try, for example, the eye exercises, and then you might want to consider, once you graduate all that, seeing a muscle activation technique type provider. My biggest concern is that the provider has an interest and understands how to deal with CCI patients more than anything else. So for example, last weekend I was in Reno lecturing to a bunch of physical therapists, and we had some physical therapists in the audience that clearly loved to see CCI patients. They had specialized in it. So I started a list of those providers because if they've got the interest, they will figure it out. And if they see those patients on a day-to-day basis, they will start to understand how to take what it is they do and apply it without flaring those people up. Vera, hi, Dr. Centeno. Whenever my neck flares up, I get tingling in my small fingers and severe tightness in my forearms. Could that be part of CCI symptoms, or is it more likely to come from the lower neck? More likely to come from the lower neck. Now, listen, it's certainly possible in upper cervical patients to get a lot of thoracic outlet, and that can irritate the lower trunk of the brachial plexus, so that can cause numbness in the little fingers. So it could be either upper cervical, probably related to thoracic outlet syndrome, or lower cervical, C7T1, C6-7, that kind of thing. Greg, when a PICL client is there, do you also treat other areas such as TMJ, shoulder at the same time? Is that procedure solely PICL? No, Greg, we often treat other areas as well. Now, a lot of that depends on how the patient will tolerate this stuff. And so what I mean by that is we have patients who I can identify on exam that have central sensitization. So we have to take a less is more approach to control the flare-up. And those kind of patients, we're not going to treat other body parts. But that's only about 1 in 10 to maybe 2 in 10 times. For those other 8 to 9 out of 10 patients, we are treating multiple areas, so it's possible to do. Now, the ones I like to treat are the ones that are directly involved in the spinal kinetic chain. So that's going to be pretty frequently shoulders, thoracic spine, SI joints, lumbar spine. But if someone wants me to treat their left wrist, their right knee, at some point it becomes too much for the time allotted that we have. And I'll generally refer them to local Regenexx providers to do some of that kind of stuff. But if it's kinetic chain related to what's going on with their CCI, I try to treat it. Johnny, I'm 7 weeks post PICL, 3C went out with laser exercise last weekend. When should I start back up now that I got my atlas orthogonal adjustment yesterday? Yeah, Johnny, so whatever it was that threw you out, so let's just make something up, right? Let's say you got to the level 1 exercise on the third exercise. And it was the third exercise that threw you off. So when you go back to it, now that things are calmed down, go back down a step and see how you do. Again, that's threading that needle between enough activity so that you can start to get stronger, but not so much that you get thrown into a major league flare-up. Alex, PICL yesterday, a lot of pain, very limited range of motion. Should I be trying to move around, not overdo it, or just not move much? Yeah, Alex, I think that it's always better to try to get up and move if you can. So I don't believe in just not doing anything. Now, obviously, there are patients where they feel bad enough or sore enough where they don't really do anything. But at the end of the day, just realize that you want to thread that needle. So what does thread that needle look like at this early phase? It means if you can be active without flaring yourself up, meaning if it's pain is going to be pain, then be a little bit more active, move around, move that neck a little bit, get up out of bed, go to the bathroom. If you need assistance, get that. If you can go out and take a small walk, do that. So those are the kind of things you should be thinking about. Now, if your body is saying no, no, and no to all of that, then you have to listen to your body. Mike, I had bad C1, C2 overlap, and my occiput keeps going out of alignment frequently, which both seem to really be the main trigger cause for my symptoms. When my occiput pops out of alignment, it seems to be the biggest culprit in causing POTS-like blood pressure drops. Use of my tongue with speech, bad nerve headache, sensation of film-like feeling that runs across my forehead. Are there symptoms also normally affiliated with occiput going out of alignment? Yeah, Mike, I mean, all of those are pretty typical C1, C2 type symptoms. So none of that sounds too unusual for CCI. Brett, hey, Dr. C, my main issues are all neurological, constant severe brain fog, dizziness, POTS, numbness left side of the neck and left arm. UCC doesn't help at all either. How common is this in CCI? Fairly common, Brett. Dizziness is an upper cervical thing. Now, numbness on the left side of the neck and left arm may be related to CCI. It might be related to other issues in the neck, thoracic outlet, etc. But I would say that symptom complex is maybe 1 to 2 out of 10 of our CCI patients that we treat right now. It is true that more commonly you'll see neck pain, headaches with that, but we also have patients that don't have that feature. What are your thoughts on tirzepatide for reducing inflammation? Yeah, I think the GLP-1s are a good idea for reducing inflammation. There seems to be some pretty good mounting research that by reducing the metabolic syndrome and helping patients drop weight, they reduce overall systemic inflammation. So I think they're probably a good idea. Obviously, you have to get your doctor to look at all that for you. Is grade 1 L5S1 antilisthesis treatable with injections? If it's gone all the way to 25% across the vertebral body, I would say less treatable. If it's just a small antilisthesis of L5 or on S1, and it's not fixed, meaning that it can be reduced and then goes to slip, reduced and then go to slip with extension and flexion, then it's more treatable, meaning with injections. God always wins. Are there current efforts to teach and train other doctors nationwide more about CCI and treatments? And here in California, it's almost non-existent. Yeah, so we are working with a Florida clinic right now. I think I've talked about that before. That'll be our first experiment with teaching U.S. physicians. Now, listen, I lecture all over the country. This last weekend, I lectured in Reno, which is pretty close to the California line there. And there were a lot of California physical therapists there preaching the gospel about what this is, how it's treated, etc. I've lectured probably in front of 1,000 different physicians who have an interest in orthobiologics right now, between physicians and chiropractors, and on these topics of what is CCI, how it's treated. So it's getting better and better from that front. But as far as our training of a clinic to do upper cervical facets and eventually PICL, that has begun. OC Dirty Rat, should I also wait to return to baseline pain level before returning to curve correction techniques via CBP and traction? Yes, I think returning to baseline would be important there. Mike, you got to stop writing quite so much here, man. I need you to be a little bit more brief. I have a small amount of liquid in my ear. When I wake up in the morning, I've been to 3 different ENTs for evaluations and trying to gain answers, but have had no explanation. I have a drain tube in one of my ears when I got a lot of fluid from. What are the chances that it's cerebral spinal fluid? And is there a way to confirm if it is? If there's a chance it's not CSF due to CCI, do you have any insight on what could be caused from fluid buildup? Yeah, don't do ENT, Mike, so I can't really comment there. I can tell you that there are problems like spiky leaky syndrome that can lead to small amounts of fluid coming out. You can test the fluid to see if it looks more like cerebral spinal fluid, but you got to catch some of that fluid and go to a doctor that knows how to test it. Ultimately, I'd probably look up spiky leaky syndrome to get some idea of what that is. If you just search it right here on the YouTube channel, I did a whole Facebook Live on it. Billed in public, I'll be scheduling for PICL. And for the last 11 months, I have not needed NUCA care. I still have symptoms. This changed my treatment plan. It might, but usually not. So, but again, I'd need to know more. So that would be a telemedicine evaluation first, and then probably more recent movement-based imaging to see if there's still instability. Chandler, you pre-screened as a PICL candidate. I've got a C1C2 overhang of 5 millimeters in DMX, but I think I also have type 3 CCI. Is it worth getting PRP with Dr. Williams in Atlanta since you're booked till February? No, yeah. Posterior injections aren't going to help a 5 millimeter C1C2, so a lot of it just depends on how much you have in the way of resources. If resources aren't an issue, then give it a shot, but it's probably not going to solve the issue. So you're going to have to get the internal ligaments injected, and that's going to be a PICL procedure. So if you're more like most patients trying to conserve resources as much as you can, then I think your best investment would be just to get a PICL. Now, you don't have to book it with me. You can book it with Dr. Schultz, who's easier to get into, Dr. Pitts, who's easier to get into, etc. DRK Hardy. Can CCI cause feeling like I've been punched in the nose? I pulled on vines today. Yeah, I don't know how to answer that one. Alex, I got bilateral C0 to C4 facets, ALR transverse, ALL at C3, nuchal interspinous, yesterday with Dr. Schultz, and a lot of pain. Should I expect it to lower to fly on Saturday morning? Lower a little bit from yesterday today. Dr. Schultz was great. Couldn't have asked for a good experience. Well, great, Alex. Yeah, so generally what happens in the vast majority of patients is day over day, it gets better and better. So I would say you've got a pretty good shot of being able to go home on Saturday. But again, I don't know your clinical condition or other things, but in general, for most patients, I'd say they'd have a pretty good shot. Gut always wins. If MRI shows mild to moderate narrowing by disc bulge and symptoms are BP spikes, near syncope, off balance, ectopic heartbeats, head pressure, etc., can PICL help or surgery needed? Well, All of those things that you described are generally not related to disc bulges at all. They're generally related to things in the upper neck. If you have craniocervical instability on movement-based imaging, that would explain many of those things. There's obviously lots of other explanations for all of those things. So you'd have to have qualified specialists who look at, for instance, your heart to make sure there's nothing going on. But if there's no other explanation, then all of those things can be explained by CCI. You obviously need to get movement-based imaging to determine that. Brian, the paper reference to a question about repeat intradiscals. I think you misunderstood. Long-term victims to your discal culture expanded MSCs, platelet products, genetic back pain, Pitts-Williams, no strike relation to disguised cases, repeat injections. Yeah, so I think I know the paper you're talking about, and I think what you're really probably seeing is more a relationship to the higher, well, number one, the N wasn't really big enough to go into that. Meaning that in order to determine that, you probably have to have several thousand patients. And what I mean by that is that the number of patients that are going to develop discitis, even in an injection population, is going to be very, very small. So what does that mean? What that means is, let's say we inject 100 patients, we might not have one case of discitis. In disc injections, for example, the rate of discitis is somewhere between 1 in 300 and 1 in 3,000. But let's say it's 1 in 300. That means that in order to get 10 cases of discitis, we'd have to inject 3,000 patients. So as you start to see the prevalence or incidence of discitis is so low that if we only look at 200 people and we've got 4 cases of discitis, let's say, and 3 of them happen to be repeat injections, we really don't know what that means, because we don't really need 3 or 4 cases of discitis. We need 50 to 100 to really understand if there is an association between A and B. Courtney, can 3B CCI get treated by posterior PRP, or is PICL more fitting for this type? Yeah, 3B is going to be more PICL because that involves the anterior longitudinal ligament, so you have to come from the front to get that. I am local in Denver area, post both EPICL. I went to my AO within 4 days. Great. There are docs with your credentials in the Northwest. There are not. A8, my IPA-PT has found severe abdominal right-sided fascial tension in my rib cage area near the gallbladder and colon. How much could this contribute to right-sided subaccipital dysfunction? Probably not. But again, I'd have to know a lot more about what's going on with you, right? At the end of the day, has there been an injury up here? Is there instability up here? Is there scoliosis also involved in this? But in general, we do see relationships between what goes on in the thoracic spine and rib cage, and in the neck and in the suboccipital area. But there's a lot of different variables that drive that equation. So it's not that simple to look at a small amount of information and to be able to draw a conclusion. God always wins. Thank you so much, RC, for your sincere generosity and compassion in taking care of your patients, addressing the concerns of this community. Never how much this means to us. Thanks. Well, thank you so much. Yeah, I spent a lot of time doing this, that's for sure. And, you know, it is a very rewarding thing as well. On the Reddit thread recently, because we've been reaching out, trying to improve data response rate for our coming paper, we have been getting some really touching stories back, and I try to share those when I get those back on the Reddit thread. So thank you. IPA-PT also found severe internal rotation of my right leg. We are working on that, intense PT and manual therapy. How much could this be driven right side CCI issues also? Again, not enough info in which to really help you there. Vero, could CCI aggravate an existing tinnitus? Mine was unrelated to my ear, but it has gotten louder and more frequent since my neck injury. However, sometimes it goes away. It's possible. Most of the tinnitus related to CCI is pulsatile, usually due to intermittent compression of the internal jugular vein. So I would say that if you have now more pulsatile tinnitus, it's certainly possible that that could be related to CCI or other things in the neck. Courtney, what injection spots are directly correlated to dizziness? Injection spots. So generally, Courtney, dizziness in the neck comes from the upper cervical facet joint. So that's going to be the C2-3 and C1-2 facets. With injections into those. In addition to that, if we look at other spots, could be the suboccipital muscles and tendons, tendons themselves. Ali, injecting the upper facet joints help proprioception, dizziness, brain fog, derealization. Proprioception can be off when the upper cervical facet joints are involved. And if they are involved causing that, then injecting those can help. Mike. Thanks, Mike. My anterolisthesis is 8 millimeters in, I think pretty stable. I've had it for years, but pain got worse than my neck. So if it's not moving, then we're probably not going to get rid of the anterolisthesis at L5S1. Now, we may be able to help the pain, the symptoms, but a fixed anterolisthesis is probably not going to go away with injections. Would you dirty rat? Thank you, Dr. C. Incredibly helpful that you are so accessible. Thank you. Greg, time-wise for PICL and in the chain, can C0 to 2, C3, 7 stenosis, SI joints, lower scoliosis, lower TMJ, and hydrovase. Let me know once. Possible to do all of that at once. Yes, I don't know what you mean by C3 through 7 stenosis. So again, stenosis is not necessarily symptomatic or doesn't really necessarily mean much. We would have to determine what's causing symptoms, and then we would target those areas. So just having stenosis on an image is really meaningless, right? Because if we take 100 people my age off the street right now, half of them are going to have stenosis in their neck, but they have no neck pain, no decreased function. They're living their lives large. They don't have any problems. So just knowing there's stenosis on the MRI doesn't really get us much to figuring out what's causing your symptoms. Hey, Dr. C, working on your fascia, can you heal from CCI? Not usually, no. DRK Hardy, does CCI affect the trigeminal nerves? It certainly can. We've got a good number of CCI patients who have trigeminal nerve issues. Vero, thank you so much for answering questions. It really helps. Thank you, Vero. Alex, is ice really harmful? Someone to use it in the first 2 weeks for pain? You know, it's not harmful, Alex. You're not going to get deep enough with the ice for it really to do much to the deep internal ligaments. So I always tell patients with a PICL procedure, especially that first night, many patients can get acute pain relief by just putting a ice pack at the back of their head here and really freezing that area down. So put it down there until the skin goes numb, and then take it off, let the skin sensation come back, put it on again until the skin goes numb. And that can really help, right? Because it can reduce the irritation around the occipital nerves, which can lead to headaches after the procedure. It can reduce some of the local superficial swelling that might be causing pain. And a lot of my patients really find that helpful for the first night or two. Greg, happy to help. Is intense pain at the base of the skull a symptom of AAI, CCI? It can be. Normally that comes from the C1, C2 facet joint and other things. So it's very common to see CCI patients who have problems with the C1, C2 facet joint, and as a result, pain across the base of the skull. Alex, thank you. Your clinic's truly top-notch. Felt super safe and good hands the entire time. Well, thank you, Alex. Okay, guys, any last-minute questions here? I'm coming up on an hour. Just looking at the number of questions, I think, I don't know, maybe up to 50 questions so far, something like that. But any more last minute questions I can answer, put those in the comment section now where you are, whether on YouTube or Facebook. Vero, okay, good to know. Does natural anesthesia usually progress? I mean, slips more. Vero, that has a lot to do with why it's there. The two main reasons are a break in the pars intra-articularis bone and degenerative changes in the L5S1 facets. If it's due to degenerative changes in the L5S1 facets, that's the reason to kind of get it treated, tighten the ligaments, decrease the pain, get more active, get more stability, so it won't progress, or at least you can reduce the progression. But if it's related to a break in the pars, then it will more easily progress. Thank you, Erica. Will PICL help the pain at C1-2? Is there another treatment? Yeah, Navo, in order to be a candidate for the PICL, you'd have to be unstable at C1, C2. So we'd have to do movement-based imaging to determine you are unstable. Now, many patients that have chronic pain at C1, C2 do very well with a C1, C2 facet injection. That's a specialized injection under C-arm fluoroscopy with contrast and digital subtraction angiography, usually a PRP into that joint. The biggest problem is that that's a higher risk area, and most physicians don't do them and really aren't trained to do them. So you've got to find a physician who does, let's say, at least a couple of dozen of those a year and has been doing them for a while. So they have a couple hundred of those cases under their belt. Greg, just to clarify, did we meet with you right before PICL? Yep, you do. So if I'm going to be doing the PICL procedure, we will meet. We'll go through a hands-on physical exam. We'll discuss the different areas we're going to inject, why we're going to inject them, etc. So that's a very, very important part of any PICL procedure. Jane, I've had double styloidectomy, 4 ligaments likely cut off. What are the chances of PICL to help someone like me? Yeah, Jane, certainly the styloidectomy will, in my opinion, reduce the likelihood that we can help. How much is that reduction? It's a good question. I don't think we know that yet. But ultimately, the problem is that the stylohyoid ligaments actually help with anterior stability. So if we cut them out, you can see more instability. And so that's the concern. Now, do we have styloidectomy patients that have done well with PICL? We do. But in general, I always tell patients just to be cautious there, simply because we've taken important parts and pieces out. Why does my neck hurt and headache like upon walking, and is that CCI symptoms? That's generally not a CCI symptom, although patients with CCI can have that happen. That can be due to lots of different things, everything from poor posture, scoliosis, side bend in the spine, irritation of the suboccipital muscles, irritation of the greater, lesser occipital nerve, et cetera, et cetera. So by itself, that wouldn't be a huge indicator of CCI, but there are CCI patients who have that issue. Vera, I think I got it from gymnastics, yoga, and figure skating. I don't have any pars fracture. Stopped doing extensions, then been doing physio. Gotcha. Thank you. Have a good night. Really appreciate it. Working, not walking. Yeah, so then we get into other things, right? We get into, does the work involve looking down, overall occupational health things, etc. Okay, guys, I think we're at more than an hour now. I want to thank everyone for the great questions. This next week, I think I'm going to move this to its usual time on Sunday. So expect to see this more on Sunday than on a Thursday night. We had lots of people watching. We had lots of great questions. It's wonderful to see because that's how people learn, right? We all learn when patients get to ask questions. Other patients see, hey, that's like me. Now I understand a little bit more about what they mean by when they say that, etc. Jane, Dr. H doesn't believe that's like to add my instability, though I know it did quite a bit. Would you please do a video on the subject? Jane, I got a bunch of them on that particular subject. What time on Sunday? Usually we go off at Sunday at 10 a.m. Mountain, which is noon Eastern. or 9 a.m. on the West Coast. Okay, guys, you all have a wonderful week, and we will do this next week on Sunday. Thanks so much for all the great questions, and great to see you all here.